and welcome to the PCR training presented to you today by the California Department of Aging. This is Lila Tomasian speaking, and we are very glad to see not only so many of our providers in attendance today, but also representatives from managed care plans. We've got a great training scheduled ahead, and once again, welcome to our training. As a sort of welcome, I also wanted to note that the PCR data is very valuable to us in the state and other stakeholders in that it's the only data of its kind that characterizes the CBAS program, and it's used extensively by CDA and other sister departments for reporting purposes. And we also use it here at CDA for monitoring purposes. So it's very important, and we are so glad to have you all in attendance today to listen to this very important training. If we could see the next slide to introduce our presenters for today. So we've got Denise Peach, Chief at the CBAS branch, who will be one of our presenters. Myself, Lilith, I will be presenting. And also we have Adam Smith, our data and program analyst here at the branch, presenting at today's training. Let's go over our agenda for today. So we'll have our welcome and housekeeping to get things started. We've got our training objectives. We'll also talk about the last PCR submission and lessons learned. We have some time devoted to talking about the definitions on some things we've revised and some things we want to clarify further. And then also we want to overview the revised submission instructions. And then finally we'll recap with a summary of what we've discussed so far. And then we'll have...
The broadcast is now starting. All attendees are in listen-only mode.
Time devoted to questions. So let's go to our housekeeping items. So just so you know, this webinar is being recorded, and we will be posting it on our website. For those of you who have registered, we sent a copy of the slides to you all around, I think, 1:15. We did get some of them bounced back, so some of you may not have received them. So please keep checking on our website. We hope to have them posted by tomorrow. The PCR form and instructions and the FAQ document will also be available on our website if you follow through the link. Or go to our main webpage at aging.ca.gov, go to Programs and Providers, and then select ADHD and CBAS. It will be under the Forms section. And then once again, at the end, we'll have about 30 minutes devoted to questions and answers. Next slide. So our main objectives for today's training are to share lessons learned from the June 2014 PCR submission, which was a massive undertaking for us all. And then based on the last submission and some internal changes, we also wanted to clarify reporting requirements for the December 2014 PCR submission. And then finally, a point that we'll continue to stress throughout today is that we want to ensure all providers understand the PCR submission instructions to remain HIPAA compliant. And with that, I'm going to turn it over to Denise, who'll do a brief recap on our latest submission for the month of June, and we'll share some of the lessons we learned here at CDA.
Great. Thank you, Lilith, and welcome, everyone. A special welcome again to the managed care partners who are joining the call. This is a subject today that is very primarily focused on what the providers, the CBAS providers, need to know about how to submit this routine report that they've been submitting since about 2002 that captures characteristics data on the participants they serve and then allows us to share statewide data about the program, description of the individuals served by CBAS statewide. So this is primarily focused on our providers and how to work with us in getting this data to us, to get it clean, et cetera. But we're glad that the managed care folks are listening in, and I suspect that you'll find that if you're new to the program and new to the participant characteristics reporting that CBAS providers do, that you'll be pleased to find that there's some good data that is being captured about what's happening with the CBAS program and at your individual contracting centers. So thanks for being here. If we flip the slide, I want to talk a little bit, as Lola said, do a little recap about some of the things that we've learned. We learned since the last time. So just to back up a little bit, a couple of years ago, we decided here at the Department of Aging, with some amount of nudging from the provider community and advocacy community, that we needed to update some of our data capture that we do through this participant characteristics report. And we started the process of updating this report. As you all are well aware, there were tons of changes going on over the last couple of years, and so the timing was not great for a really significant set of changes that we wanted to do. So we scaled back our plans for doing a really significant overhaul of this report, and we scaled it back to more modest expectations around capturing, for example, one of the most important things that we captured in this new version of the report that we launched in June of this year was to capture the SIN, the client identification number, so that we could cross-link data, other data that we have here at CDA and other data that DHCS has. So that was a major addition to this revised report that we revised for the first time since 2002 and that we launched in June. We also added all of the activities of daily living and instrumental activities of daily living. We defined them as they're defined in the individual plan of care, so we can link it very nicely with the current IPC, and we added those. And then we did a couple of other tweaks to the form. We actually deleted a few fields that we felt weren't valuable data collection points or were just too confusing, and so we deleted those. But we made fairly modest changes with this form that we launched in June of 2014. What happened in June of 2014, or a little bit before that with the submission of this report, is that we now went to, first of all, we went to a twice-a-year submission of the report, and that was for June data and December data, point in time that we would have you submit by July 10th and by January 10th, and we're going to continue to stay with that program of twice-a-year data submission. And what happened was, we had some early indications that we had some problems with getting the data transmitted to us securely via email, which was what our plan was within our current data systems that we have here at CDA. What happened early on, our information security officers raised some concerns. We had done a survey of all of you and asked who of you had secure data transmission capabilities. Many of you told us what yours were, and we were expecting to work with those, and we had some preliminary problems. So we pulled back from that, and it was kind of at the last minute, right before the July deadline for submission of the reports. So what we did was we developed what we refer to as the abbreviated PCR, the abbreviated participant characteristics, which does not have participant level data, but just captured the totals for each of the CVAS centers. So at least we could get aggregate data without any concerns for security and transmission in June. So that was a little disappointing for us, and we hope to be correcting that today with asking you to give us the participant level data, and that we've got some provisions in place to making sure that we get it securely, but we went for just the abbreviated data in June. What happened also, we have there on that second bullet on this slide, is that CDA, because of some of the transmission that ended up happening, we had some providers who sent us the entire participant level data, even though we had done webinars and had asked them not to send that full participant level data report, and we had some of our providers who did that and sent it to us through regular email. So we issued them a fairly strongly worded letter about the importance of not doing so and violating HIPAA requirements. So that also happened in July. We also had a number of providers that just were slow to get the report submitted. We had to work with them individually to kind of stay on top of them and get them to send the data. So a few of our lessons learned are things that we've learned before, which is that the vast majority of our CVAS providers are compliant and they do what we ask of them. I think that you all share our goal of capturing really clean, good data that characterizes what's happening in the CVAS program statewide. And the vast majority of you get that right and are willing to submit things on time, and then there's a few folks that we have to really work with to get to do this right. So we hope that providing more information today is going to get you all geared up to do this right and get you on board for doing it for the December data that's coming due in January. Again, so important data and important that we get it right. So further lessons for us, that we just need to give more clarification on what we mean by what needs to be reported on this form, be really clear about our definitions. So we've made some revisions to those, and we're going to talk about that today. No matter how much we work on these things, and I can assure you we have spent lots and lots of hours and working with you, getting your advice, listening to what you've said to us about the lack of clarity in things, and we've worked to get our language as clear as we possibly can, but it's always a humbling effort trying to do this and get it right, because it's a challenging thing to communicate these things really clearly. So with that said, we definitely learned that we need to continue to work at that. We have an extensive FAQ document that we deliberately did not post and release today because we want to hear what you say today in case we've made another error or we haven't gotten something perfectly clear. We'll go back and tweak it before we get it posted after we hear from you today. And in your usual spirit, I can tell you that we already, before we even started the transmission of this webinar today, we were already getting some pointers from all of you and some questions and some comments. So true to form, you guys are very active in letting us know how to get this thing fine-tuned. So we're going to provide some additional guidance because we can tell that we need to do that in order to get the quality data. So here's some overview statistics from the June data. So it all was not lost because we didn't get the participant level data that we wanted. We did get the aggregate data from all of our centers. And so here are the numbers. And I just want to add that these are also numbers that are posted on our CDA website, on our dashboard. These are numbers that are available to anyone who's interested. And through our CDAS waiver amendment stakeholder process, we developed this dashboard, and it's become a central feature to capturing what's going on in the program. And I know that a lot of the providers and advocates and plans rely on all the data that's out there on the dashboard. So these are up there now. So the June data showed the program, 95% of the participants Medi-Cal, 5% private pay. You can see our diagnoses data. We captured a very limited amount of diagnoses data, but we've got dementia, intellectual and developmental disability data, and mental health diagnoses data that's up. So we've got that posted, and then we've got status and needs data that is collected regarding individuals who take psychiatric medications, behavioral symptoms, fall risks, use canes, walkers, or wheelchairs, hearing and visual deficits, communication deficits, percentage of people who speak English. So those are all some of the fields that are captured on this participant characteristics report. I want to highlight right here that we have put an asterisk under fall risk there and said that we believe that the data that we received on this field is questionable. So it shows an 87% fall risk currently on data that was reported in June, and we're going to talk about the fall risk category today and some of the challenges we had with dealing with capturing that data. But we've got the asterisk next to a few things here that we think are points where we need to address some lack of clarity out there about what should be reported. So here are the data on the ADLs, IADLs. Again, this is a brand new field in this PCR form. So you've been reporting characteristics for a long time. You've been capturing ADLs and IADLs on your individual plans of care, but not capturing it anywhere else for our statewide look. And so now we have it on the participant characteristics report. And here's what it shows. Predictably, we've got some of those IADLs that require oftentimes higher cognitive functioning, higher functioning abilities, and they're running with really high percentages of the participants statewide. Designated they're a little bit different color, requiring assistance accessing resources, meal preparation and assistance, transportation assistance running very high, money management, medication management also very high, and then baby assistance up there under ADLs that came out very high. So that's our first look at statewide data under ADLs, IADLs. So we're happy to have that. Special diet, again, high percentage. That's been a high percentage for many years. The psych services item, I think that we're gonna need to clarify some things around that, and we're going to try to do that today. Speech therapy services statewide, very low. It has been for some time. I think that's the lowest number we've seen there as yet. And again, some questions about our medications administered at the center. We're going to talk about that today, and self-administered medications at the center. We think that we need to clarify that further, as well as the restorative PT and OT. We think that percentage is a little bit high, so we're going to go over that definition again. And then skilled nursing services still running a little high, so we'll talk about some of the finer points about what we're looking to capture in those items.
So let me talk about this slide a little bit. When we received all the data from our providers, we basically aggregated them and started looking at them to look at trends, etc. And what we found was that there was some questionable information that we were receiving. And these were some of the indicators that we wanted to point out to you as you are compiling the next report that's coming up in January to make sure that you are submitting correct data to us. So for example, if we notice all or majority of enrolled participants reported as receiving services in a specific category, then we would question it. So for example, if 90 to 100% of participants were reported as receiving skilled nursing services, that number seemed exceedingly high to us just based on the definition of skilled nursing services. These are typically very invasive services that are most likely not provided to 100% of the population at an average center. Another indicator that we looked at is data reported in one field is in direct conflict with data in a related field. So for example, if a center has reported 100 participants as total enrollment, 90 of whom receive medications at the center, and then 60 of whom self-administer medications at the center, this makes no sense because you can't have some of them get medications at the center and at the same time self-administer them themselves. Or, for example, a center has reported 100 enrolled participants, 80 of whom are at fall risk, and only 2 use a walker, a cane, or wheelchair. If you have 80 participants at a fall risk, then most likely you have majority of them using a walker, cane, or a wheelchair. And then finally, another indicator is data reported conflicts with observations at the center or other center reports. So, for example, when our surveyors are on site, they're doing lots of participant observation, and they may notice that a participant is, or a few participants are self-medicating medication, but the PCR submitted by the center indicates there are 0 participants who self-medicate at the center. So at that time, our staff would talk to the center staff and just try to figure out why the report says something that's in conflict with the observation. In addition, we also receive the MSSR from the centers, and some of the enrollment numbers may not be similar to what we get on the PCR, so that's, again, something that we cross-check to make sure we're getting the right numbers from the centers. Okay, let's see what else we have next. The other thing that we check for is basic things, completion of the form. So we have here all the necessary header information that needs to be completed. And what we noticed in the last submission is some of this information was missing. So maybe we're missing a center NPI, which is indicated, I think, in purple there, or a lot of times the languages were missing, so the centers were not indicating with an X mark what languages are being spoken at a center other than English. And most of our centers speak a language other than English as well. And then the other really important field that we're missing was total participants enrolled. So we need this information to do any type of percentages for centers. So please make sure you include this information. And then finally, make sure you include the date of the submission of the report. So just to recap, just simple data validation. Please make sure all the header information is complete. And then when you're reporting total participants, make sure that these are equal to or greater than any total reported in a specific category. So if you're reporting 150 total participants as enrolled in your center, you can't possibly have participants who have dementia equal to 155. It just doesn't make any sense. So that's incorrect. But if you do have 150 participants enrolled and only are reporting 55 participants who have dementia, then that seems a little less questionable to us. So just basic checks like that. Please make sure you're doing that before you submit that to us. And then next we wanted to focus on the definitions. So we've clarified many of them. A lot of it is a recap from our May PCR training, and then we've also made some revisions based on some questions we got from providers after that May training.
All right.
Okay.
So I'll take it for a little bit here. So revised definitions in this new form that is not posted yet, right? We haven't posted it yet after today. So for the 2014 version of the form, we have revised definitions, not the Excel spreadsheet at all, but just tweaked the definitions, and none of those changes should change, by the way, any of the ways that our software vendors and whatnot are working with this form. These are just clarifications for all of you who are indicating these fields. So dementia, intellectual and developmental disability, and mental health diagnoses, we made a minor tweak there, and we'll talk about that in a minute. We made a pretty significant tweak to our fall risk category, and a clarifying tweak to our group and individual psychological services. In the definitions only, the fields are still exactly as they were in the spreadsheet. So the clarifying language that we added to each of these diagnoses is simply this, that when participants are diagnosed with one of these diagnoses, and they can also be diagnosed with another as well, obviously, and we're saying report all diagnoses separately in the appropriate fields. So, so just making sure that, that there's not anything here about primary or anything, it's just anything that applies, if all three apply to an individual, then you would check all three of those. So we clarified that in the definitions. Under fall risk, we revised this definition, and this one was one of the more significant ones, because what we found as we started to receive more questions from all of you during the time that you were preparing the June report was that that what we had thought was going to fix some of our quality problems with this fall risk in the previous spreadsheet by asking you to use an industry standard tool, that wasn't going to be enough to address issues around fall risk because of the types of tools that people are using, the providers are using, that we have some tools that don't have the option of no risk. So everyone is identified with some level of risk. So to address this, what we have decided is that what we would like to capture here in this field is high risk only. Okay, so this is, I just want to clarify that it's not that we don't think it matters that individuals have moderate to medium level risk for falls or low risk for falls. This is all about just capturing of data here so that we can have a way to define and describe the acuity level of people served in CVAS. So this is a discretionary call on our part to look at just the high risk being reported in this field so we can capture that. So it matters the level of risk, but we want to just have you focus on high risk for reporting here. And there's an extensive clarification in our FAQ document that we will release after today, and it includes some really specific information and references about the different kinds of tools, and it gives you some website links if you're still trying to decide what kinds of tools you want to use at your center. There's some important information there. We worked with a couple of our PT experts in the provider community. We thank them for that in helping us to get this information together. So check the FAQ for more information on fall risk. The definition revisions for group and individual psychological services. What we did simply here was we added that these are the services that are scheduled in box 22 of your IPC. And so to clarify that we're not looking to get reporting of social services that are scheduled in box 21, but the psychological services that meet the criteria that are specified in the manual, for the Medi-Cal manual for the IPC, and that are captured in box 22. So these are services provided during the 6-month, during the TAR period on the IPC that are provided by the mental health consultant, and the very specific information about who can provide mental health consultant services are all available on the definitions and instructions in the community IPC section, and there's the reference right there. So again, it's not that it doesn't matter that individuals are getting good social services. That's a backbone of the CVAS program, important that they're getting the core services, but core services are required services, and what we're looking to do here is capture the number of individuals who are getting the additional services from the psych consultant or mental health consultant at the center. So this is not, again, if you're following the instructions in the Medi-Cal manual for box 22, it's not going to say that you're providing assessment, and that's what needs to be reported here. If you're assessing, say the LCSW is providing an assessment, that's not ongoing services, that's assessment, that wouldn't be captured in box 22. But if the mental health consultant, LCSW, whoever it is providing the services in box 22 during that TAR period, then that's what will be captured, and that's what will be reported here on the PCR. So this is straight from our FAQ document, and again, this is generated by your questions. So I want to review some of this. I think that this is something that was in the FAQs from our last webinar, but we want to review it because we had some concerns about the quality of the data that was reported under medications administered by the center. So just to clarify, what's to be reported here: medications that are, and they meet all these criteria. Prescribed by a physician, administered by the center nurse, and it's on a routine medication order, not a PRN. So it's not an as needed. So there's some more clarifying information here about what is a routine order, and it's defined as a medication that's administered until discontinuation order is written or until a specified date is reached. And we give you an example here. This could also include over-the-counter medications, so long as, again, they're prescribed by a physician on a routine order and administered by the center's nurse. So there's a few more sort of do-nots here. Don't report a PRN in this field. Don't report standard orders. Don't report self-administration of medications. So again, these things are all important, what's happening with an individual's medications at the center in the range of things that are happening, but what gets indicated in this field here is the medication it's administered by the center that meet these qualities here that are listed under this definition. Next, for clarification under the medication questions, again, this comes out of our FAQ document, so it will be available on our website. The question is, if a participant needs reminders to take a medication, do we report it in this field? And so, again, we say yes if the medication meets definition number 18 above. So it would have to meet all of those criteria. And so we say, to clarify, if an individual requires any help to take medication, including queuing or reminders, they are not independent for self-administering medications at the center per our regulations, okay? So this individual requires reminders to take medications, therefore the nurse is basically administering those medications and has to meet the guidelines for administering medications that are found in Title 22 under that reference. So there's a little bit of additional clarification that we put in there about that. And I want to highlight that we, once again, no matter how many times we edit our slides, we still have one or two errors that we have to let go through, and probably several of you have already caught it. It's not number 18 above, it would be number 22. So we'll correct that before we post the fact document. But the important thing to remember here is that you have to meet the qualifications for it being prescribed by a physician, administered by the center nurse, and on a routine medication order. All right, next question. Under number 24, this is under self-administered medications. So when you're reporting self-administered medications, we think we had some errors here, as Lilith kind of indicated before. So we have an FAQ here. Are participants who self-administer over-the-counter medication included in this field? So we're talking about the self-administered box on the report. The answer would be yes, if the medication is, once again, prescribed by a physician and is administered independently by the participant on a routine medication order, not a PRN. So we're not interested in capturing the PRNs here because we want to look at a certain level of participant that's receiving services and a certain kind of care in the center. Skilled nursing, again, this definition is what was in the FAQ, is in the one that's currently posted on our website, but we want to call your attention to it again because there were further questions about it. So the question is, what do we want to capture here? Can you provide further clarification on this field, and why aren't we capturing anything besides this skilled nursing? So here's our answer. Professional nursing services are listed in the Welfare Institutions Code. So we don't make this stuff up. It's in the statutes for ADHD, CBAS, and it refers to direct one-to-one care provided by a licensed nurse per physician's orders and the participant's care plan. Such care includes but is not limited to catheter insertion, injections, ostomy care, complex wound care, blood glucose testing. So it's the more invasive procedures that are sort of captured under that skilled nursing definition under 14550.585 in the Welfare Institutions Code. So that's the particular kind of nursing service we want captured in this field. So skilled nursing services, by definition, in that same place in the Welfare Institutions Code, does not include the items that are listed under A1 through 4. Observation and monitoring, administering of medications, routine blood pressure testing and monitoring, liaison with the healthcare providers, supervision of the ADLs and personal care services. Those are all defined in that same statute, but they are not under the skilled nursing definition. So, so we don't want them reported in this category. So basically what we're saying there at the bottom is CDA is collecting information specifically for skilled nursing services component of the professional nursing services. So professional nursing services is the larger definition of nursing that happens in a CDOS setting. Skilled is what we want you to report here so that we can better understand the acuity level of participants served at the CDOS centers. Hearing and vision deficits. So this is a brand new definition based on an issue that one of our providers brought up. Very good issue. So the question is, can we clarify which participants should be recorded in the field for hearing and vision deficits? And we've listed participants appropriate for this field include those for whom IPC Box 12 glasses or other vision aid is checked because they use any kind of glasses, vision aid, or hearing device. So when those boxes are checked, we want to make sure that they are captured in this field. And then individuals with known hearing or vision deficits but who do not currently use any device. So, so if you know that an individual, for example, is blind, not using glasses, or any other visual aid, then they still have a hearing deficit. And the important thing here is that if you're generating your Excel spreadsheet, your participant characteristics report from the IPC Box 12, then you'll probably need to do that data validation that Lilith was talking about earlier, where you manually enter the participants who aren't currently using those hearing or vision aids because they wouldn't be included in Box 12, that they should be reported in this field on the characteristics report. So some amount of verification, data verification and manual entry is just part of what you'll need to do in ensuring you get us the good, clean data. Special diet. So a question here, again, we want to make sure that we clarify because I think we have a lot of folks that are entering some standard sort of heart-healthy diets here under this category. So we've done a lot of consultation with our dietitians, provider dietitians, and our dietitians here at CDA to address this question. Is a cut-up diet considered altered? Is a cut-up diet considered altered texture? So CDA has further defined this field as follows. So special diet, a therapeutic diet prescribed by a physician and provided at the center to help manage chronic illness or other medical conditions. This includes portion control, high-low calorie, low salt, low cholesterol, low fat, no concentrated sweets, diabetic and renal diets. It also includes modified textures when the modified texture alters the nutritional content of the food, such as a mechanical soft, pureed, or tube-feeding diets. So what this excludes is those diets that are provided as standard diets to prevent chronic disease, such as heart-healthy diets, which would be sort of the no salt, no fat added. It would exclude also cut up or chopped, but that don't have any alteration in the nutritional content. So this is about alteration in the nutritional content. Also, the tube feeding is not formulated for a specific medical condition or internal our parenteral nutrition. So that's a clarification that we've gotten on special diet. We've had lots of questions about special diet over the years. I think the main thing that comes up is our standard center heart healthy diet a special diet? And the answer is no, because it's not a therapeutic diet prescribed by a physician to manage a chronic illness or medical condition. When it is, then that's what gets recorded here. Next slide.
Okay, so next up we have the form submission instructions, and we have some revisions here that Adam's going to cover for us.
Good afternoon. Again, I'm Adam Smith. I'm the Data and Program Analyst, and I speak with many of you out there on a routine basis about things like MSSRs and PCRs. So today we're going to talk about submission process for the PCR. So this slide is recycled from the May training. This just talks about the submission process overview, that the report will be submitted to CDA by July 10th and January 10th, and that'll be for the preceding month. So for July 10th, it'll be June data, and January 10th will be December data. Also, upon request, if surveyors are at the center and they need that data. And it's going to be submitted how? That's going to be through secure email. CDA is going to generate a secure email to all providers prior to this report being due. That's the new process that we're going to go to. So we're going to talk about that here. So what does CDA mean by a secure submission in a Microsoft Excel format? So there's two parts to that question. A secure transmission means that it cannot be sent by regular email. That does not meet the HIPAA compliance. It has to be submitted through secure email, which requires a password to access. That is HIPAA compliant. This is the email that we are going to generate to each center, and the centers are going to reply back to. We're going to keep messaging on that secure email and replying back to our generated email. So in Microsoft Excel format, so in that we're talking about we do not want the providers to scan this form and send it in an Adobe Acrobat or to hand fill it out and send it as a fax. We need it to be sent in an Excel file, so that's .xls or XLSX depending on which Excel version you have. And again, that'll be attached to our secure email that we generate to you. So here's the new process that we're going to, our new rule, so to speak. The CDA is going to generate a secure email prior to each reporting period. So for this one, it'll be January 2nd, 2015. That's right after we come back from the holidays. CDA will work with designated staff at each center to ensure they've received the secure email. And each center will reply directly to that secure email from CDA, and they'll attach the PCR to this. We know that some providers that use the software companies have the ability to generate their own secure email. And for this process, we do not want that. We want all the providers responding back to the email that we generate, so we're the control point for all the secure emails. So the next steps after this webinar, we have developed an electronic survey for providers to update their information regarding the staff who's going to submit the PCR. So that way we make sure that we send the secure email to the appropriate person, because we may have a program director or administrator's email here on file, but it's actually somebody else who fills it out. So we sent the slides out and we're going to post them, but we want everybody to go ahead and go to that link, fill out that very brief survey. I think it's 6 questions. Please complete that by next Friday, December 19th. That'll let us know who we're supposed to send the email out to on January 2nd. And we need an updated survey from all the providers. So if everybody could fill that out, we'd be appreciative, and this process would go much smoother. So again, this is directly from our FAQ. We had some people that wanted questions about, can you explain what center-generated secure email means? Is this something we have to purchase? How do we set it up? Is this something we need because we're submitting confidential participant information? So a secure email, it protects sensitive data such as the confidential participant characteristics, PCR data like SIN, date of birth, name, that kind of thing that's on there. It encrypts the message prior to the submission and requires a password from the recipient to unlock the message and the attachments. This protects the content from being read by any but the intended recipients. To ensure HIPAA guidelines are not violated, CDA is going to generate the secure email for all providers. Each provider must then directly reply to the secure email with the attached PCR. Again, regardless of a provider's capability to generate a secure email, CDA is requesting that providers submit the PCR attached to the secure email they receive directly from CDA. And you can replace CDA with my name, Adam Smith, because I will be sending you all these emails. So again, this is another measure to ensure that HIPAA guidelines are not violated. So we appreciate everybody's due diligence on this so we can keep everybody's participant health information protected. Thank you.
Denise, if you can recap our main points.
Yes, I can. Before we go to questions, sure. So some of the things that we want to make sure that everybody got today, we repeated it a few times, and I'm sure we'll repeat it through questions, that the participant characteristics report is used to report aggregate data to characterize the program and for our use in program monitoring. So it's very important that we get it from every single CVAS provider and that we're able to capture that and share that with all interested parties through our dashboard and various other reporting that we do, especially now to CMS. It is the only kind of data that is provided by the providers and that captures the kinds of fields that we have in the participant characteristics report. So it's extremely important to all of us. The revisions and definitions that we clarified, we hope will allow a more accurate way of capturing the data and provide the ability for more meaningful analysis. The form needs to be completed and submitted in the Microsoft Excel format twice a year. So that's, again, it's sort of a refresher on some of the information we shared with you when we did the webinar back in May. That we're capturing it twice a year for 2 points in time in the year. And you're going to send it to CEA via that secure email that Adam was reminding you about, and that you need to provide, you need to follow the submission instructions to avoid any violations of HIPAA guidelines and to otherwise sort of compromise our ability to make this reporting happen. So we really implore all of you to follow those instructions. And I would add also that one of the things that we do extensively on our back end, as Lilith was indicating about sort of the basic data checking that we do, quality checking, we'll aggregate all the data, put it all in one big spreadsheet, and we'll look at all of the centers and all of the data fields, and we'll look for things that just seem wrong. And some of them just are what I'd call screaming wrong. You know, so the things like Lilith had pointed out about there's 150 people that are enrolled at the center, but you have 155 people noted in one of the categories for a particular kind of characteristic. So there's some things that if you just look at it and do a little data checking, data validation before you transmit to us, that you can capture on your end. And I can assure you that because of our commitment to getting this good quality data, we're going to be checking it on our end. So we're going to find it if it's wrong. So I hope that you will work with us and save us a little time and energy. We get cleaner data to start with, but assure you that we will be scrubbing it and working with you as much as is needed to get it correct if you're giving us data that doesn't make sense or that's otherwise wrong. So I just want to emphasize that point as well. So I think from there we're going to go to all of the questions that are pouring in, and I hope we can provide more clarification for you.
Okay, so we've got a few questions on definitions. So the first one has to do with fall risk. Fall risk may not relate to the fact that if the participant is using a cane, walker, or a wheelchair. For example, we have a couple of clients who have severe dementia. They don't use any cane, walker, or wheelchair, but because of their severe confusion and memory problems, we'll put them on fall risk.
Okay, so when we have the fall risk FAQ posted, you can take a look at this in greater detail. But yes. So the answer would be yes, you're correct. We understand that, and what we've asked for to be reported in this field for this report is that you report any individual that's indicated as high risk by using a standard industry tool for assessing fall risk. And so in the case that you're describing, it sounds like you have individuals that are high fall risk because of their cognitive capabilities. They may not be using any other assistive devices. That may be true, but the tool that you use in evaluating their risk per falls indicates that they're at high risk, then that's what we want reported on this form. So absolutely correct. So if there was an implication that they had to be using assistive devices, yeah, no, That's not true, that they wouldn't need to be.
Let me see, there were some other definition-related questions. If a participant does not have a diagnosis of dementia, but the professional staff has noticed dementia for MMSE, that's MMSE, we can add the dementia in the report.
Okay, so the answer to that question can be found right in the definitions on the spreadsheet itself, and we have a separate definitions form that's on our website. And it says right in the first sentence for dementia, individuals diagnosed with dementia. So again, it's not that it doesn't matter what you're describing there, that clearly there are individuals for whom a diagnosis is pending, has not yet happened. That's an important thing for you to planning your care. But as far as this report, what goes in the report is individuals who have a diagnosis of dementia. And then there's more information in our definition on that form that will clarify further, we hope, what dementia disorders are.
Okay, another one on mental health disorder. If the participant has a mental health disorder and is seeing a psychiatrist or mental health counselor in the county mental health clinic, do we need to report it? Please clarify.
Okay, so again, the definition, if you look at the definitions for mental health diagnosis, it says in Field 3, individuals diagnosed with a mental disorder as defined in the Diagnostic and Statistical Manual 4 or 5, and there's further definition, elaboration on that. So again, where that individual is receiving services, whether in the CBAS Center and through County Mental Health, one or the other, that's not a consideration for this reporting item. What we're looking for is individuals who have a diagnosed mental disorder.
Here's one on skilled nursing services. Is the physician's order what determines the skilled nursing service?
So I'm going to be a little bit out of my league here. We don't have any nurses in the room today. So by our definition, we're saying the skilled nursing services are the services that are provided by a licensed nurse per the physician's order and the participant's care plan, and that meet the definitions that are in the Welfare and Institutions Code. So if I'm understanding the question correctly, that's the way it's defined, and we have put in a little bit of additional information in our instructions and definitions to sort of clarify that we're talking about the more invasive types of procedures for skilled nursing.
Okay, this one, it seems more of a clarification on behalf of someone regarding special diets. And no added salt diet translates into a 4-gram NA diet, which is a special diet.
So I'm not sure how to take that one. I'd encourage you to look at the FAQ when it comes up, and I guess for the individual who's sending that question, if you still feel like you're unclear, I'd be happy to have you send a question or call us in the CBAS branch, and we'll make sure that we get an answer for you from one of our registered dietitians. I don't want to speak out of turn, but we've attempted to at least clarify that this is not the routine, no added salt type of healthy diet. What we're talking about is the low or restricted. So to the extent that our FAQ, I hope, and our definitions answer your questions, that'd be great. If they don't, let us know through an email or a call, and we'll see if we can run down your particular question.
Okay, and here's another one on special diets. Our standard diet is low fat, low cholesterol, low salt. This is checked on our medical form as an order by the PCP. Is this a special diet since it includes 3 things that meet the criteria and the doctor ordered it?
Yeah, so again, if you go to the definitions, diet prescribed by a physician and provided at the center include portion control, high-low calorie, altered texture, diabetic, renal, no salt, no added salt, no concentrated sweets, and low cholesterol, low fat. Yeah, I think, actually, I think that what I just identified is that we have an error in our current definitions that we need to still tweak, because we said it was a low salt, no, low cholesterol, low fat. So I think we've got a problem with our definition. So we'll tune that up. And if you could go back up to that slide where I hope we have in the FAQ we have it. We have worked this through. There you go, a drum roll for our new rule. Okay, so special diet that we got in our FAQ clarification, and it does look like we've identified a problem still in our definitions in the document. So these are therapeutic diets that are to address and manage chronic illness and other medical conditions. It's not the standard heart-healthy diet that would be the no added salt or no added fat. It's actual calorie or portion control, high and low, low salt, low cholesterol, low fat, no concentrated sweets, diabetic, renal would be the examples of it. So not the standard heart-healthy that's given to everyone because they are seen as therapeutic diets as opposed to something to manage chronic illness and medical conditions.
Okay, where is the group individual psychological services? Okay, I'll repeat. Where is the group individual psychological services to go on the PCR? I am just not seeing that box. So that would be under, if you want to pull up the report, Adam, we can just show it. It's under services, it's under services needs.
Yeah, so I'm looking for the box. It is.
So it's right there. So it's box 24.
Box 24. Group/individual psych services. Was there any more to that question besides just where the location is?
That's what it was. And then we are getting an offer from Lydia to give a Starbucks card to the most accurate report. So
the what? I'm sorry.
We're getting an offer from Lydia to give a Starbucks card for the most accurate report. So we're going to hold
okay.
it to Lydia.
All right. Okay. Let's make this competitive. Yes. Clean data is important to Lydia and CADS as well as all the rest of us. That's great. Thanks, Lydia.
Okay. Why doesn't medication administration count as skilled nursing care? We're not considering anyone else qualified to do it.
Right. So again, this is not a judgment about the importance of medications administration or anything else. It's strictly us using what's already in the statute for definitions. So if you were to look at that 14550.5 for the definitions of nursing services, CBAS nursing services are defined there. There's 5 different kinds of professional nursing services. Skilled nursing services is a subset of those professional nursing services, just like medications administration is. So all we're looking for there in that field is the skilled nursing that's defined under that A5 there. So again, medications administration extremely important. Understood that it is a highly professional thing and highly important. But what we're capturing in this field is only that those invasive procedures under skilled nursing.
Okay, so we've got a question on assistive devices. Last time in training, we only reported on the PCR when they actually use an assistive device, but now you are stating that at least box 12 must be checked, so we can use a report on the PCR. So I'm not entirely
sure. So for clarification, under box 20, hearing and vision deficits, the challenge here is this. We would have liked to have done a lot more revisions to this report last year when we started this effort. We would have liked to have done a lot of things, but they would have been enormously burdensome to providers and would have taken a lot more lead time for our software vendors to retool to be able to capture certain data fields differently. So we did our best to link things to the existing individual plan of care, and to the extent we could do that, we did. On this one, we have expanded this to go beyond what's in box 12 of the IPC that asks for you to capture current assistive and adaptive devices. Under box 12, it indicates that you will check, someone uses a hearing device, you check all that apply, including a hearing device or glasses or other vision aids. So that's one way of capturing some level of deficit or need for assistive devices. Under box 20 on the participant characteristics report, we changed it to include hearing and vision deficits. So we expanded it a little bit, and it does seem that it's caused some amount of challenge for providers in reporting this, but I would just encourage you to the extent that you use box 12 to identify sort of the minimum individuals who are using devices that have challenges with hearing and or with vision, and then you have to just do a data edit to make sure that anybody who was missed, that you add those folks in because they have known hearing or vision deficits, but they aren't captured because they're not using devices. So we expanded on that box 12 a little bit. It's causing a little bit of challenge for folks, but I think that overall it's an important data field to capture.
Okay, we also have another question on fall risk. Can you give an example or two of industry standard fall risk assessment tools that you prefer we use?
Sure, it's in our FAQ document, and just does anybody have a copy of it? It's not posted yet on the website, but we can pull it up. Okay, so we can post it up in here up on our screen so you can see it. Again, we work with some of our physical therapists in the field, the providers, and we appreciate this. And we have we've got some links there to the different assessment tools. If you scroll down, add on there, you'll get the Tinetti Balance Assessment Tool, the Burke Balance Scale, the Morse Scale. We've also given you some additional fall risk information, including this multifactorial approach to assessment, prevention, intervention, et cetera, at the CDC, American Geriatric Society, and U.S. Preventive Services Task Force recommendation regarding prevention of falls. So there's some other website links that we've given you there. So hope those are helpful. And again, if they're not, I'm sure we'll hear from you, or if you have some additional things that you think that we should get out there. But we're not being prescriptive about what assessment tools need to be used. But again, to remind you, for the purpose of reporting on this participant characteristics report, we're asking for just those individuals identified with high fall risk.
Okay, and then another definition question. Is diagnosis made by a mental health consultant as a PhD in the field is accepted as valid diagnosis, or it should be done only by the MD?
All right, that's a stump one for me. So does anybody, you want to take that one, Lynn? No? Okay, so I think we're going to have to take that one and get another FAQ back out of that one, because I'm not comfortable answering that. The way we have it defined in our definitions here, we don't specify. We just talk about diagnosis, so we're going to have to do a little bit more legwork on that.
Okay, and
Thank
then
you.
We have a question on restorative OT-PT. When do we need to check restorative OT-PT? Please give us some examples.
Okay, so again, the restorative OT-PT, just like the psychological services that we were talking about earlier, if you look at the definition, we're asking you to, and that's under, it's field 28, and it's in the definitions and instructions on the report, and it says services provided directly by or under supervision of the center's physical or occupational therapist as defined in the Medi-Cal manual, page 29, box 22, instructions for additional services. So these are the services, these are not maintenance program services. These are not the services provided by the program aide for routine maintenance procedures and exercises. These are the services provided under the physical therapist or occupational therapist and filled into box 22 of the IPC, because they're provided at that higher skill level. So services essentially provided by or directly under the supervision of the PT or OT. But check out the Medi-Cal manual. If you're not clear on where to find that, you can look at our CDA website that's up on the screen there and click on I think it's additional resources or websites, and it will take you out right to the Medi-Cal manual, and you look up the community-based section and you can find the instructions for filling out the individual plan of care. So those are basically policy guidelines for what gets put in that IPC. So follow that link and take a look at the instructions there. But essentially it's anything that goes in box 22 because it's provided by that OT or PT.
Okay, and then we have some technical questions, I believe, so let's see. Fields for names and ID number are small. When typing the information, we cannot see the entire information in the field, and this field is fixed and restricted.
So I'll go ahead and take that. We had to limit the size of the field so we can fit everything on one sheet of paper. So since you're submitting the report electronically, it's okay if the last name or the first name goes beyond the parameters of the field, because when we import that electronically, we'll be able to have that information.
And if you're having difficulty actually seeing what you're typing on the screen, you can just make the document actually bigger. Just
Yes,
zoom in. Yeah,
yes.
so that should be helpful.
But again, if anybody has any problems with that, they can feel free to contact me at CVAS at the numbers above, and I can help with those kind of technical questions.
Did you want to add anything else to me?
Yeah, I was just making sure that we addressed the expanded. Did they have an expanding the rows in there, or was that? I know that we talked about that in one of our FAQs about the centers that have problems with expanding the number of rows.
Yeah, so depending on which version of Excel that providers are using, some people have problems with things like checking the boxes at the top or expanding the rows to include more participants. Again, if you run into those kind of technical problems, just go ahead and contact Adam Smith at CVAS, and I can work with you to either get you a version of the form that will work with you or something like that.
Okay, we use a CAD/CARE software, and in September it was updated in order to generate PCR automatically. Do we need to contact RTZ and update CAD/CARE again? Those changes that you made in the report. We haven't made any changes in the report, just slight revisions to the definitions, so I don't think there's a need for you to contact RTZ to have them make the change. I believe they're actually attending the webinar, and we'll definitely follow up with them to make sure they're aware of all the changes we've made to the definition. So if in case there is something they need to change, they can, but we're not anticipating that because we didn't make any changes to the report itself.
Right, so, and I think one possible exception might be with the fall risk definition if it's being pulled from box 17 of the IPC. But again, what we were talking about before, I think applies with regards to data validation. So you've got software vendors who we've been working with and who've been working very hard to give you guys good tools. Those of you who have them are working with the software providers, so you have good tools so you can get a push button assembling of the report from data that you capture in your systems. But despite how hard those folks are working for you, you still have to do some kind of data validation. So I think that there are going to be fields that can't that don't marry up perfectly with the IPC, and there's going to be a need for some kind of data validation on the part of the person who's submitting the report. So if box 17 of the IPC is what's populating your fall risk category, and what's captured under fall risk is low level of fall risk, if that's what you're putting in your IPC, then you'll need to go back and do some kind of data validation to make sure that you only have those with high fall risk identified. So, but again, we've been working pretty closely with the software vendors, and I think that we're all aware that there's not a perfect marriage between the participant characteristics report and the IPC, but that it's a great platform for at least getting started for the formatted report.
We have a question about the SurveyMonkey. Are we going to get the survey in email, or do we need to fill it out on the CDA website? So the link to the survey is included in the slides, and we're going to send the slides to everyone and then actually post them on our website. And what we can also do is maybe include them in the FAQ document so that you can pull it up from there as well. So that would be a follow-up item for us. Let's see. Question regarding the secure email on January 2nd. Would this be the only day that CDA will be doing it? Because our center will be closed on that day.
So I think we picked the second. I'll just take this and we can talk about this internally. First of all, when you do the SurveyMonkey, you're going to answer just a few quick questions that just say who your point of contact is for doing this report, what's their email address if they have a direct one and a direct phone number. So it's really simple. There's a copy of it right there up on your screen. So it'll take you less than 5 minutes to tell us that information. So then we know who we're dealing with. So the center may be closed. We're going to send the email to whatever you designate here. So there shouldn't be a problem. The email will come into that email box, and the person who opens it on Monday should be the person who is designated here, and that's the person we're going to be expecting to return the email secured with the Center's Participant Characteristics Report, and that's the person who will be calling if it doesn't show up. So that should be pretty straightforward. Again, it doesn't matter that the center's closed on the 2nd. But if there's some special need that you have, I would just encourage you to pick up the phone and talk to Adam, because he's going to be the guy managing all that.
And then there was another similar question, where do we send the updated information of the person who will be responsible for sending the report? So again, you're going to fill out the SurveyMonkey, and that way we'll know who the individual is. Okay. And another question on services provided. For the category, group, individual, psych services, do you only want participants with mental health diagnosis?
Wow, that's a different spin on the question. Okay, so the way that box 24 is defined, group and individual psychological services, is services provided by the center's mental health consultant and or as specified in the Medi-Cal manual, the community IPC section, box 22 instructions. It includes individual and group plan schedule for participants with diagnosed mental, emotional, and behavioral problems. So yes, it is for those individuals with the diagnosed mental, emotional, or behavioral problems, which makes sense. That's why they're getting the services, because the psych consultant is brought in for those individuals with more significant needs. So that's the way we have defined it.
Okay, I've got another question on prescribed medications. For the prescribed medications administered by center, would this be inclusive of participants who do not take medications at the center but require supervision assistance as indicated on the IPC? For example, verbal cueing to ask about medications taken at home is done as part of the nursing plan. Would this be included in this field?
Okay, so can you give me the last part? So we're looking at self-administration of medications. The individual is self-administering at the center.
At home.
Okay, so what we're looking for here is the individual self-administering at the center. So let's make sure that we have all of our definitions aligned.
Their IPC says they require supervision assistance. So their ADL, IADLs indicate they require supervision.
Right. So that would be if you're populating the box 27, self-administers medication at the center, with something that's coming off of box 11 of the IPC, and that's going to be a little bit of a problem. So I would be interested, actually, if we've got our CoreLink and RTZ and TurboTav folks out there, and if there is, you can just maybe ping us with an answer to that question if you know how you're populating box 27 of the characteristics report. I'd kind of be surprised if you were pulling that off of box 11 for needs assistance with medication, because those are different kinds of issues. So clearly in box 27, the category is self-administers medication at the center. So to be reported in this field, the participant is administering medications at the center. It's not just that they need assistance with administration.
So that would be captured actually under ADLs and IADLs on the PCR. But them actually receiving the medications at the center.
Right, so they're two different things. Exactly. So someone has a level of need that they need some amount of medication management, and it's checked in their IPC box 11 for medication management needs, but that's different from self-administering a medication at the center. That would be the individual participant is self-administering at the center. Mm-hmm. It's a different, I would be surprised if there's any kind of a connection there. So those shouldn't be tied together.
Okay, I'm looking at just a couple more. Let me see. Okay, regarding conflicting data related to receiving medication at the center versus self-medication, we have a participant who we give daily meds to, as well as having their own supply of PRN meds to self-medicate as needed while at center. Do we categorize only as receiving or as self-medicating, or do they fall into both categories?
Wow.
Yeah.
That's a very unusual situation. Okay, so if I understand the question correctly, and I'm going to guess we're going to have to get one of our nurses on this. We don't have any of our nurses here today; they're all out in the field. So, so the question is: you have an individual for whom you would meet the criteria for checking box 26 for prescribed medications are being administered at the center, and that individual also self-administers PRNs.
Mm-hmm.
Yeah, we're going to have to go back and look at that. I think that we've tightened up our FAQ and our definitions so that we're not looking at PRNs
And they don't
at
have any
all.
queuing or reminders.
Right. So I think that the PRN issue, I think, is what's going to be what sort of disqualifies them from being reported in this category. So if they have medications that they are self-administering because they meet all the criteria being prescribed by the physician and they're safe to self-administer, they would not also meet the criteria for having medications administered that met those same criteria. That doesn't make any sense. So, if there's further questions from that individual, I just invite you to call us up, and we'll see if we can get you talking to somebody, one of the nurses in the crew that can talk to you about this. Questions all starting to overlap at this point?
Yeah, a little bit.
Hope we've answered most of them.
Well, we got a thank you note for all the clarification
Oh, good.
and for all our hard work. Thank you.
Good. Well, thank you for the thank you note. And thank you all for hanging in there with going over these things. I think it's a really important exercise. And again, every time we do it, there's some little nuance that we hadn't thought about. So it's important for us all to work, together to get these things as clear as we possibly can so we can get the clean data. And Lydia, I will remind everybody, has a Starbucks gift card of some unspecified value riding on the cleanest report submission. So we'll have to figure out what the criteria are for that because a good many of you get it pretty clean. So finding the best is going to be kind of challenging, but a challenge from Lydia.
And then we also had a clarification regarding OT and PT. So are these restorative services basically separately billable services?
Those are, so back to the language of separately billable, which we were all working with under Senate Bill 1755, the reforms prior to the elimination of ADHD, we referred to those as separately billable, yes. So they're the things that go now in box 22 for additional services is how they're referred to because we never fully implemented our separately billable services, but it's the same concept.
Okay. I think that's it. Let me just do one final check. Someone's asking for the information on the fall risk assessments to be brought back up. Can we bring that up? It's from the FAQ.
Yeah, so let's pull that back up. We still have a few more minutes left. And is there a question related to it?
There wasn't a question, so let's wait a couple of minutes. There's a question on prescription PRN med, so let's take that one first.
Okay.
A participant has a prescription PRN med for pain but complains of pain daily. Can this be considered as routine medicine because of this circumstance?
I think we had this question come up once before, and we actually checked this out with our nurses, and the answer was that if somebody is having something come up with a regularity, that if the medication PRN was actually being given with that kind of regularity, they would liaison with the physician to change the order. So I think that was the sort of nursing approach to that question. You go back to the physician and get the order changed.
Okay. And I don't see a question on a follow-up question on fall risk. So
we just let you know that the fall risk, this FAQ document, we're going to make a couple more tweaks to it based on a couple little things that we found today, and we'll get this posted by the end of the week so you can look at this at your leisure and go take a look at those websites if you're interested in doing so. So that's the fall risk FAQ that's up on the screen.
Okay.
Soon to be posted.
We're getting another offer from Lydia.
Okay, another offer from Lydia?
To do a training on fall assessment.
Oh, fantastic. Okay, so CAMS does some fairly regular webinars. It's a great service that they make available to members, I think sometimes to even non-members at a fee. It's a great opportunity for providers to get training and assistance and clarification. Oftentimes, Lydia will invite Jeannie Smalley, my counterpart, and I means to sit down and help out with some webinars. They provide all kinds of great training and highly recommend it. So, Lydia, if you're willing to do that, we'll participate and help to whatever degree we can.
And then we got another question on mental health services. Is the participant receiving mental health services from the county mental health clinic not by our OSY? I'm assuming mental health consultant or psych consultant. Do we need to report in the box of individual, group, and psychological services?
Okay, so these are services provided at the center. So if I understand the question, you're saying somebody's getting services through county mental health, but if they're not getting services provided by the mental health consultant at the center, then they would not be recorded here. So let's just say, for example, that you have your social worker who is meeting, say, responsibilities with regards to liaisoning with the county mental health, and they've got something scheduled in their box because the social worker is doing that kind of communication, routine coordination around the care plan. That's something that's in box 21. It wouldn't meet the group and individual psych counseling. If your mental health consultant is doing it and doing it on a routine basis, it's on the IPC, it's in box 22, that would be counted here.
Okay, I think that's it.
Wow. Okay, so that's pretty good. We're a little bit ahead of schedule.
Sorry, one more.
Oh, one more.
One more. Do we report the following on the PCR? Participant receives assistance in transferring to the tab at home, but since center has no tab, do we report assist on IPC and PCR?
Okay, so you've got a question about, we're looking at bathing here, and your question is, do they meet the assistance level for bathing? And so I would defer part of that to your clinical people, your OT, your PT, your nurse, to reconcile the level of assistance or supervision or whatever it is that that individual needs. But if what you determine is that they need assistance and it meets the definition there that's in box 11, because we've made that consistent with the PCR reporting, physical help required, even with device, they need assistance. And if you decide that that's what they need, then they would in fact go into be reported on the PCR for that item. So Adam, if you can pop back up our contact slides, I think we'll highlight a couple things here before we let everybody go. One is that if you want to, if you're not a CBAS provider and you want to subscribe to our new CBAS Updates newsletter, you can click on that button in the slides and it will take you to our CDA website, where you can sign up to get our new little newsletter that provides really good program updates for anybody who's interested in CBAS program, including providers. You can subscribe to there. CBAS providers, we've already signed you up, so you don't need to sign up. So you're already subscribed. But anybody else from the managed care plans or anybody else who's joining us today and you want to get those updates, please click and join us in staying informed about what's happening with the CBAS program. There's all our contact information if you have further questions after today, or if we've confused you at all. If it has to do with technical issues, data submission, Adam's your first contact. Lilith, other than that, if Adam's not available, and certainly any of the rest of us can help muddle through all those technological questions, but they're the best ones. And then for definitions and whatnot, just call our main number and we'll get you somebody who can answer your questions. So thank you, everybody. Thank you, Adam and Lilith, for all your hard work on getting us ready to go for this December reporting. Thank you, CBAS providers, for all the due diligence you're going to put into getting us some good, clean data and doing it, transmitting it to us in a secure way. Don't get excited and hit the button send before we're ready to go. You got to send it on our secure email. And if you have any questions about that, call us, because we want to get it right. So thank you for participating, everyone. Thank you for the sound effects, Lilith. That was great. All right, thank you, everybody.
All right.